Thanks, Chris. Yes, I remember 10 years ago, you rotating through my clinic, and you were way ahead of the fellows even then. So
Oh, thank you.
it was just a pleasure to work with you, and I appreciate the opportunity um, to share these thoughts with you and your group in Seattle. I wish I was actually in Seattle and not sitting in my clinic, but that'll have to wait. So I have no financial disclosures, but I will say that some of the work that I'm going to talk about this morning was supported by an ACR RRF Clinician Scholar Educator Award. So if you've ever been this person and thinking, I'm standing here, or as I am now sitting here, I normally stand, and I'm teaching, but is anybody really learning? Then this talk is for you. And you may be asking yourself, you know, what's a rheumatologist talking to us about learning theory, cognitive psychology? And like some of you, I imagine, I came to medicine and teaching and academic medicine with really no formal training in education or educational scholarship or anything, you know, that remotely looked at the science of learning. And I think as many of us, sort of learned as we went how to teach, what works, what doesn't work. And what really prompted me to take a deeper dive into some of the science of learning was about 5 or 6 years ago here at UNC, there was a major curriculum reform. And I was tasked with developing a new course, which is called multi-organ synthesis, which is essentially autoimmune rheumatic diseases. And so I really took that opportunity to learn a lot about cognitive psychology, about how we learn, just really in preparing to develop this course. And so I'm going to share with you some of what I have learned and a little bit of how I've used that knowledge. And hopefully at the end we can have a few minutes of back and forth. This is a difficult sort of format for me. I tend to stand and walk around and talk to people and get feedback. So, you know, I think this is going to be a little bit of a challenge, but I hope you'll stay with me and enjoy, and please put your questions in. So we have three major learning objectives today. The first is to understand the role of retrieval practice in learning, and I'm going to define these terms for you in just a bit. We want to understand the concepts of spacing and interleaving in learning. And then hopefully today or at some point, you're going to start to develop a plan if you're a teacher, and all of us are, I think, to develop a plan to incorporate some of these concepts into our teaching strategies. So here's the outline of my talk this morning. First, I'm going to talk about retrieval practice. We're going to discuss spaced learning, interleaved learning. I'm going to talk about just a few practical applications or how I've used some of this knowledge in my teaching. And maybe we'll have a few minutes at the end to talk about the impact of this pandemic on our teaching, because clearly that's going to be our next frontier over the next month. So I'm not going to talk a lot about adult learning theory today, but I do want to mention this really as a background. When we teach in medicine, we're teaching adult learners, and it's helpful to know what the goals of adult learners are. And we're all adult learners, so you should know this. So we all learn best in an environment of mutual trust and respect, obviously. And a lot of times adults as learners really need to know why they need to learn this. So, you know, in school when we're young, we learn it because it's in the curriculum. When we get older and we say we need to learn something, it's usually because we have a need for that knowledge. So the learners want to set their own objectives. They want to be able to evaluate their own progress. And they want to acquire a knowledge that they can apply, that they can learn from their experiences and through active involvement. So much of what we do in teaching adult learners, we have to keep this in mind. It needs to be experiential and it needs to be active. We're not going to talk a lot about that today. We're really going to talk more about the cognitive psychology. But the cognitive psychology is going to exist in this framework when you apply it. So this is Bloom's taxonomy, and Some of you may be familiar with this, and this is a classification system which is used to define and distinguish varying levels of human cognition, starting from knowledge. So, this is sort of factoid, remembering previously learned information, ability to sort of recall, define, describe, and arrange, to comprehensive, classification, estimation, summarization, application, right? So applying the knowledge that you've gained and your understanding of that knowledge to some task or problem, analyzing how it all went, synthesizing information from multiple analyses, and ultimately evaluating all of your learning and what you're doing. So there is sort of a hierarchy of thinking skills that goes along this pathway. And we can use this taxonomy to guide the development of methods, assessments, and curricula. And if you recall, a minute ago, I gave us 3 learning objectives. 2 of the learning objectives were really knowledge learning objectives. They were very low level. You needed to understand really the concepts that we're trying to use. So it was sort of foundational knowledge. But then in the 3rd one, I was asking you to develop a plan. And developing a plan is really a much higher level of thinking skills. So we start with knowledge skills, comprehension skills, and then move our way up. A little bit about how we learn. So obviously, we gain knowledge from our environment through our sensory system, touch, hearing, vision, however we explore our environment. When we don't attend to this information, say you're sitting in a lecture and you're daydreaming, or you're on your text messages, if you don't attend to this message, it's lost, and we're all familiar with that problem. However, if we're attending to our senses and processing this, it goes into our short-term memory. We often have to rehearse that information. Say you're at a cocktail party and someone introduces you to Joe, and you think, oh, I got to remember Joe because I'm going to have a conversation with him. You may rehearse his name. That goes into your short-term memory. Again, you may lose that if you don't attend to it. And then ultimately, with processing, it may go into your long-term memory. Sometimes memory from the long term is lost. We're all familiar with that problem. You learn that in medical school. You learn that, but there's no way for you to retrieve that long-term memory. So some of that memory can be lost over time. So let's think about, knowing what we know about how we learn, how do students learn and study? And this is just a study that was done asking students, about 150 students, how do they study? And many of you will be familiar with this. Reading, rereading, textbooks, practice problems, flashcards, rewriting, study groups, all of these things that we may do when we're studying. So this is a common study error, and I think I probably have a ton of textbooks somewhere in boxes in my attic that look something like this, although I never really got into multicolors. Many of us will read, highlight, reread, and it turns out, as I can attest to myself, this is very ineffective for long-term retention of knowledge. So you may get by cramming for a test like this, but you're unlikely to sort of retain that knowledge over a period of time through these kinds of strategies. So first I want to talk about the testing effect. And I'm not talking about ABIM examinations or final examinations or these sort of summative tests when we think about that, but I'm really talking about more formative testing. So as we self-test when we study. And the concept is that testing, as opposed to reading or studying or highlighting and all of this, really enhances the retention of knowledge. And I'm going to hopefully show you some examples to prove that point. So again, the first idea is really a retrieval practice. So when we test, we're trying to retrieve that knowledge, either rehearsing it in our short-term memory or retrieving it from our long-term memory. So again, we have our sensory input. And again, sensory memory, if we attend to it, it ends up in our short-term memory. We may rehearse it. It becomes encoded and goes to long-term memory. And then as I mentioned, some information may be lost over time, but the key here to remembering and retaining information is to constantly or repeatedly retrieve that information. So, you know, we do this in a lot of different ways in our practice. Some people may self-test, they may use flashcards, they may do all kinds of games in their head. But if you constantly testing your knowledge, you're much more likely to retain it. And this is kind of an interesting study I want to share with you that examined long-standing assumptions regarding the effects of repeated studying and repeated testing on learning. So is it the study or is it the test that really imprints that knowledge, okay? And what are the effects of repeated study or encoding or repeated testing, retrieval on learning and long-term memory? So this is a little bit of a complicated study, and so I want to just walk through it with you so you can understand it. So these were students who studied 40 Swahili English word pairs. So Swahili being a language that not very many people are familiar with. So it's going to be a completely foreign language. And in group one, the subjects studied these word pairs, and they were tested on 40 word pairs and studied 40 word pairs 4 times over the test period. Group two, once a pair was recalled, in other words, they got it correct, it was dropped from further study, but tested on each subsequent test period. So there were 4 test periods. And I'm going to show you a diagram in just a minute that will explain this a little bit more clearly. Group 3 recalled pairs were dropped from further testing, but studied in each subsequent study period. So they studied them each time, but they only tested the ones that they had gotten wrong. And then in group 4, once they recalled a pair, on subsequent cycles, they were dropped from both study and test period. And so this diagram shows it to you probably a little bit more clearly. And let me go over that again. So group 1 had a study period, a test period, a study period, a test period, and so on. And each time they studied and tested all 40 pairs throughout the whole time. So 8 periods, 4 studies, and 4 test periods. In group 2, they initially studied and tested 40, and then they no longer studied the ones that they got correctly, but they were tested on all 40 in each subsequent cycle. In group 3, again, they only dropped the ones that they had gotten correctly from the testing, but they continued to study them. And in the last group, they were dropped from both the study and the testing cycles. So the total number of trials actually was most for the group 1 and least for group 4. So you can see how this was set up. And so amongst the groups, interestingly, this was their performance during the learning phase, during these 4 study and testing trials. And you can see that all groups attained 100% mastery within the 4 trials. Great, so they learned it in the short run. And the students were then asked how often they thought they were going to remember the pairs in 1 week. And on average, students in all conditions predicted that they would recall about half of the pairs in 1 week. So I'm sure you guys remember Dory. Dory had a thing about forgetting. But this is what happened. They brought these students back after a week and retested these 40 pairs. And what they found is the students in conditions 1 and 2, where they were tested each time, had much better recollection of the Swahili English pairs than the students who were not tested on all 40 pairs throughout the 4 teaching cycles. So what this showed was that the testing was really very important. All of the students maintained mastery in that first learning period, but in order to retain that information, having tested it repeatedly was strongly associated with recollection of these pairs. So I think this is a really interesting study, and has been shown in a number of different disciplines. So this one I just showed you was on language retention. This has been done in science retention. This is a study of college students that were studying a short science test using one of 4 methods. And students who used retrieval practice tend to answer more direct questions as well as inference questions correctly after a period of time. So this concept of testing and retention of knowledge has been shown in a number of different studies. So this is my retriever, and I can't do this talk without talking about my little Luna, who's taught me about retrieving a lot of different things. She likes to retrieve all kinds of things. So this is Luna when she was just a baby, and you can see this is me here, and we were in the vet's office, and I was sort of taken aback by this, the structure of a dog's leg, which is very different than the structure of a human's leg. And I was sort of teaching my husband, who's taking the picture. Luna is paying close attention, probably more close attention than my fellows and students pay. And so we had to snap that shot. This is a few months later. Obviously, Luna is very interested in what's going on here and is thinking about becoming an ENT dog. Soon after that, when she was more full grown, she showed what we call a strong appetite for medical information. Here she's just eaten the New England Journal of Medicine. And in this, she's got a slide. She's got a beeper on her neck. She's holding the hepatology pager. She's not good enough to hold the rheumatology pager, but that's Luna, my medical dog. But she's my retriever. So how do students study? This is the same slide I showed you just a few minutes ago. This practice recall or self-testing, which I've showed you, is probably one of the most effective practices, was something that most students did not do. And so that's something that I think we should remember and use as we are doing our teaching, evaluating our students and working with our students, is to try to develop systems where they can develop self-testing and practice recall. There's also a concept of desirable difficulty, and the desirable difficulty is a learning task that requires a considerable but desirable amount of effort. And if you can do that, you can improve long-term performance. I mean, we've all seen this kid. Some of us may have had this kid. Some of us may have been this kid. But this idea that you're struggling with a concept or you feel like your head is going to explode, I think we've all been here. This is actually a sign that you might be learning. I think there's a limit. I think when you get to this stage where you're crying and hitting your head against the wall, that might be a little bit too far, but some degree of discomfort is really very essential to learning. And the young physicians in the group may be familiar with some of these. These are a number of sort of quizzing programs that you can use to test yourself. They have been shown actually to be very useful in retention of medical knowledge. Firecracker, Anki, and Quizlet are just a few of these programs that are available online or on the apps on your phone. Next, I want to talk about massed learning. And we've all seen this. We've probably all been to this. The Cleveland Clinic's 6th annual basic and clinical immunology for the busy clinician. So you go there, I guess, for a weekend and you just force a lot of immunology in your brain, and then you're sort of good to go. There's an epigenetics boot camp. There's an emergency medicine boot camp. Everyone has a boot camp. Probably every fellowship has a boot camp in the summer. But how much of this do we really retain? And I want to share with you the myth of massed learning. We've all been to these sessions, and at the end, you're empowered, you have this sense of mastery, you've got this, you have a high level of comfort with the material because you've engaged with it in a very robust way over a short period of time. But it turns out that the long-term retention of this knowledge is very, very poor. And I think we can all think back to circumstances that that's true. I personally have been to many immunology boot camps, and I think each time I retain a little bit more. I build on the knowledge I had before, but I don't retain the whole thing. These are some data from Europe on long-term retention of basic science knowledge among doctors after graduation. And you can see, and we're all familiar with this, that our knowledge does decay over time. That is actually very normal. The question is, how do we teach and learn and review to retain that knowledge? Some of you may be familiar with this. This is the forgetting curve. And this is actually from the 1880s. Dr. Ebbinghaus studied this retention of nonsense syllables, and he created these words, was a consonant, a vowel, another consonant, by repeatedly testing himself after various time periods and recording the results. He plotted these results on a graph, and he developed what we now know is the forgetting curve. And what you can see is with the first repetition, you forget fairly rapidly, and you may forget forever. If you repeat that knowledge over time, the second repetition, you're much more likely to retain that, and so much more with the third and even the fourth repetition. Now, we're probably always going to lose 20 to 30% of our knowledge. That's just the way our brain works, unless you're very special. But repeating the knowledge over time does decrease the amount of forgetting. And then there's the spacing effect, and that is that repeating information over time improves knowledge acquisition. So the spacing effect says, if you repeat it over time, you're much more likely to acquire the knowledge. But also, when we look at the forgetting curve, if you study it multiply over time, you're less likely to forget it. The key is, and this is the hard part, is to remind ourselves about the material right before you're going to forget it. I'm not really sure how you do that, but it does present a role for adaptive computer technology. So will a computer program or your cell phone or whatever know about the time that you're going to forget some information, and it sends you kind of a reminder about something that you need to sort of keep front and center in your mind. It's a really interesting idea. Dr. Kerfoot, actually, I think is a urologist in the Harvard system, and he's published a series of papers looking at this spaced education progress testing. And this is a paper that was published in 2011. There have been a number of papers before and since then, but I think this is kind of interesting. And these were actually thousands of students from 4 medical schools that were divided into groups that either did longitudinal progress testing alone, which is where they received questions, 120 questions, 4 items per week over 30 weeks. And then in the final cycle, items 1 through 40 were presented again over 4 weeks, and essentially that was an assessment. The second group was in the spaced education progress testing group. They also got 120 new questions, 4 items per week by 30 weeks. But then some of them saw the questions again on 2-week cycled reviews, and some people on 6-week cycled reviews. So they didn't just see those questions once, they came back to them in cycled reviews. And so they were constantly reminded, whether they got them right or wrong, about these questions, and they had an opportunity to again review over time. And what you can see is that even in the items 1 to 40 in the initial presentation, students who were in the 2-week and 6-week cycled review had a higher percentile scoring in the initial learning phase. In the final cycle to assess learning retention, they maintained that superiority over the students that just did the longitudinal progress testing alone, although that had decayed a certain amount. But students that were repeatedly sent these questions had a better retention of that knowledge over time. And this has been shown in a number of different studies. QStream is actually a commercial platform, I think, that Dr. Kerfoot helped to develop, and it is being used in a number of different places. But this looked at surgical clerkship students. They were rotating on a surgical clerkship, and they compared it to 136 historical controls. The students got case-based general surgery multiple choice questions delivered on this QStream platform, and eight questions were sent every day. And they also used an adaptive strategy based on correct or incorrect answers. So if you got the answer correct, you did see it again, but probably not for a longer period of time. If it was incorrect, if you answered it incorrectly, it came back to you just a couple of days later. And what they found is that for the students who use this app intensively, there was a high correlation between that and their USMLE Step 1 scores, their GPA, and their MCAT scores. So one could say that the students who intensely use the app were the sort of higher achievers, and so there's that. But there's also a question about whether this app may actually improve your score. And so I think that's for future study. The next concept I want to address is the concept of interleaved learning. And some of us are familiar, well, not me personally, but some of you may be familiar with CrossFit. And cross-training, as we all know, the action or practice of engaging in two or more sports or types of exercise in order to improve fitness or performance in one's main sport. So if you're a swimmer, you might, I don't know, run or do jump rope or whatever it is to try to improve your general fitness. This idea that you cross between more than one exercise. And this really takes advantage of a contextual interference effect. And so blocked learning, so if we had 3 skills we needed to learn, blocked learning would be you spent a block of time learning skill A, and then a block of time learning skill B, and a block of time learning skill C. If we interleaved our learning, we would spend small chunks of time together in a block, learning all 3 of the skills. This actually turns out to be much more challenging to do, to switch back and forth between different skills. But as I'll show you in a minute, it actually is much more effective for skill acquisition. So this is actually a study that was done in athletes. Again, I'm going to show you studies that were not from medicine alone, although it applies to medicine, but sports, music, other undergraduate learning, these concepts can apply to any kind of learning that we do. So this was the Cal Poly baseball team in 1994 did a study with their baseball players in batting practice. And group 1 and group 2 each went to batting practice twice a week. In group 1, they did 45 pitches per session. Same thing in group 2. Among group 1, they did massed practice. So they did a ton of curveballs, then I did a bunch of fastballs, then I did a bunch of changeups. And in group 2, though, they mixed it up and it was completely random. So actually, the students, the baseball players who did the mass learning actually felt a higher sense of mastery. But when they were tested 6 weeks later, the group that faced randomly distributed pitches, or interleaved learning, if you will, they had struggled a lot more during the practice, but they performed better on the test. So tactics that force you to slow down and struggle with material actually produce more durable learning. And that just because the practice feels easy, as it might be with massed learning, doesn't mean you're actually getting better results. So this is Carnegie Hall. And how do you get to Carnegie Hall? I'm a musician, so this is important to me. You practice, practice. But as it turns out, how you practice, and I wish I had known that 30 years ago, is very, very important. So this is a study that was actually published in 2016 in Frontiers of Psychology, and it looked at music learning, and it looked at how blocked learning or interleaved learning may affect advanced performance. And these were 10 clarinetists that were recruited. They were mostly students in their 20s. There were a couple of people a little bit older, all of whom practiced at least 8 hours a week. So these were people who were studying serious clarinet. And they brought them into the study, and each of them did both blocked schedule practice as well as interleaved schedule practice. So in the first group on the left side, they spent approximately 3 minutes reading this concerto exposition number 1, so kind of sight reading. So first look at it, then they spent 12 minutes practicing it. Then they spent a minute reading a technical study, so their sight reading, and then they spent 12 minutes practicing. And they spent approximately 28 minutes on this task. Then there was a different concerto and a different technical study in the interleaved schedule, and each of the clarinetists went through that process also. But each 3 minutes, they switched back and forth from a concerto exposition to a technical study, to the concerto exposition, to the technical study. So they moved back and forth between these different musical compositions. So all 10 participants did both the blocked and the interleaved practice. So each subject was their own control. And they were measured by the quality of the acquisition at the end of day 1 and retention at the end of day 2. And these performance trials was determined by a blind rating of the trial recording. So they recorded this, and then the professors rated the recordings. The overall improvements from sight reading to day 2 was actually quite good in all groups, both the technical exercises, the concerto exposition among the 3 raters. And when all raters were averaged, the interleaved study pattern beat the blocked study pattern by just a bit. This was not statistically significant, but just a little bit better. But what we saw in average improvement from the end of day 1, so after the study period, to day 2, the sort of test period, is that the blocked learners actually did not do well at all, and the interleaved learners did much better. So again, this idea that this desirable difficulty, struggling with the material, switching back and forth, actually improves your acquisition of knowledge, or as it turns out, technical skill, or even skill in baseball, or imagine other sports also. So here was another interesting part of this study. The students were all asked which schedule type is closest to the way you normally practice, and almost all of them said blocked study. And being a musician myself, I would say that's probably the way most of us practice. We sort of get a piece of material, we sit down, we sort of really focus on it. And then they were asked, which schedule did you find the most useful? And about half of them, maybe more than half of them, said that they found the interleaved more useful, having seen this play out. And then they asked, which schedule, blocked or interleaved, did you prefer, right? So some of those were interleaved, but some of the ones who even thought the interleaved was more useful really liked the block schedule. Again, I think because it gives us this sense of mastery, and we've all been here. I personally have been here. So here's an example from medical school, and this looks at interleaved teaching method on performance of students in radiology. These were 40 first and second year medical students randomized to 2 groups, massed and interleaved learning. They all watched a PowerPoint didactic on reading chest x-rays, and then they had massed or interleaved practice. And all students saw 6 examples of 12 radiographic findings. An hour later, they all had a test. Then students were shown 24 radiographs. 2 of them were normal, and 2 each of 11 different pathologies. And what they showed was that the students who had interleaved learning showed stronger diagnostic accuracy with a statistical significance. And so even for that kind of learning, it seemed like interleaved learning was much more useful for reading radiographs. There was no difference, obviously, between men and women, and the second-year students did better than the first-year students as expected. So I've showed you a number of sort of cognitive theories and ideas, and I'm going to just share with you just a couple of things, a way that I've used some of these in my practice. So, you know, one of the struggles that we've had here at UNC is in our rheumatology core conference. We spend a lot of time amassing papers and things for our fellows to read, and we have a weekly core conference. And so for a while, people would come to the core conference, and, you know, I was always worried, were people really prepared for this core conference? And so I asked each fellow, we started a couple of years ago, each fellow to create one multiple choice question based on the readings for the week. And the way I teed this up was, many fellows complain, and even some of us adult learners, that there aren't a lot of question banks in rheumatology. So we've got the care questions from the ACR, but if you're studying for an in-training exam or you're studying for your ABIM exam, you really want a lot of questions, because we know we learned from testing, and I think many students have already learned that. So I said, let's create some questions, okay? So this did a few things. Number one, it made people look at the material, and it assured that the fellows do at least some of the assigned readings prior to the core conference. And then we took the questions and gave it to ourselves as a pretest. So everyone sent in a question the night before. We sat down for our core conference and we took the pretest. I didn't collect it, I didn't grade anyone, I really didn't care, but it's kind of our way of teeing up our session. But then in the end, after a few years of doing this, I have this tremendous question bank that we can use for in-training exam study and board study. You know, some of the questions were good. I think my fellows learned how to write good questions over the course of a year, so they got better and better over time. But it also, I think when you get to be a good question writer, you also get to be a good test taker. And so hopefully we have used this knowledge to both help our students, you know, learn and then have a resource for the future. And then I want to tell you about another project that I worked on, which is a spaced education project. When I started talking, I mentioned that our medical school was undergoing curricular reform, and I was tasked with developing this new course. And so we used the concept of space education to really help with this. And some of you may know that the sports teams in North Carolina at UNC are the Tar Heels, H-E-E-L-S, but this is Tar Heel, H-E-A-L Quest. And this is a novel online learning activity based on this concept of space education that we developed for our first and second year medical students in the foundation phase at the UNC School of Medicine. So here is a look at our sort of curricular design, and this began with our class entering in 2014. And so this is a block system, and our foundation phase begins with principles of medicine. Then we study the immunologic system, hematologic system, cardiovascular system, respiratory system, and so on over the course of the first 18 months of medical school. And the final course, which is this multi-organ synthesis I mentioned early on, or where we teach systemic autoimmune and rheumatic diseases, is really right at the end. And it's right before their winter break and right before step one, and then on to the wards. As you know, the study of multi-organ disease, of rheumatic diseases, really builds on all of these other organ systems. So there were concepts in all of these courses that came before my course that are going to be really very important to understanding the concepts of rheumatic disease. So just a few. So obviously immunology. So do you understand you know, what a T cell is, what a B cell is, what an antibody is, what complement is. So there's all of these concepts which we're going to revisit when we talk about autoimmunity. In hematology, we talk about hemolytic anemia, we talk about iron deficiency anemia, we talk about all the other processes, clotting, that are important in our patients. Obviously the cardiovascular system, vascular biology, that's all of these things are going to build, And then hopefully when we get to multi-organ synthesis, we're going to use all of these concepts to help teach systemic autoimmune disease. And we're so fortunate actually to be at the end of the curriculum because we have the advantage of all of this knowledge. But the real challenge to me was, how do I make the students understand this knowledge and retain this knowledge so that it's ready for them when they get to the multi-organ synthesis? And so what we did was we created a spaced education curriculum. And there were 10 to 15 questions covering material presented in most of the organ system blocks. And these topics were chosen, just as I described to you, for their relevance to the study of rheumatic diseases. And all these questions were NBME style and format. And this curriculum was delivered to students via email during the blocks, or during the immunology block, they got their immunology curriculum. During the hematology block, they got the hematology curriculum. Again, with sort of my eyes and ears on what do they really need to know so that they were ready for rheumatology. 2 questions were sent daily. Students answered the questions and got immediate feedback with the answer and the rationale. And then again, with this adaptive strategy, questions were resent. And when a student answered the question correctly on 2 consecutive tries, the question was retired. And the goal was to retire all the questions in the curriculum before the end of the block. And what we did was we administered a pre-test when we got to my course that really tested all those concepts that we looked at in our spaced education curriculum to assess their preparedness. And what we found is, and we had historical controls who had not had the spaced education curriculum. So the first couple of years we didn't do it, and then we started it. And what we found is that students were much more prepared, had retained that knowledge of important concepts, so that they were really ready to jump into autoimmunity and what all that means. We looked at participation, number of questions attempted, and then, in a sort of a sidebar analysis, one of the things that we did is we garnered a lot of interest in rheumatic diseases because all of these concepts were introduced early and often. And when we got to autoimmunity, I think the light went on and people started to really understand. So this is one way that we have used these concepts in our teaching to help our students. So in the last couple of minutes, and I know we're sort of running a little bit weird today because we started late, I just want to mention the impact of COVID-19 and this pandemic on our teaching. As we're doing now, we're online learning, sort of. How do we use this format, and how do we use what we know about how we learn to use this format better? I don't have the answer to that question yet, but we're working on that, as are so many other people around the country and really around the world. We're doing telehealth. I'm doing today. This morning, I was doing telehealth, in-person health. We're doing all these things, and we're precepting telehealth. How do we precept telehealth? How do we make sure that our learners are getting the knowledge that they need from these telehealth visits? So there's so many challenges for our educators in rheumatology and really in medicine in general. How do we assess skill acquisition and development? And how do we assess personal and professional development amongst our trainees? These are questions, not answers, but I think hopefully we can use some of our knowledge of the cognitive science and adult learning theory to adapt our current educational plans to this new time. And I think we're going to be doing this for a long time. In March, we thought we were going to be emergency teaching and just getting it done until we can get back in person. But now it's clear we're going to be doing online learning in some way, shape, or form for a good period of time. So how do we take advantage of that and use what we understand about learning to make that an excellent experience for our learners? So take-home messages, we talked about retrieval testing, very, very important. Spacing your learning, cramming doesn't work, in case you didn't know that already. Interleaving your study, as hard as that sometimes is, can be challenging, but it's better for learning. And of course, we want to be able to incorporate what we learn into our teaching strategies. So if you're interested, this is a lovely book. It's a very quick read. Some of the examples I gave today come from this book. It's a book called Make It Stick, The Science of Successful Learning. It's a really, really good and quick book. And I just want to say thank you to the Rheumatology Research Foundation that funded my time and some of this work, the UNC School of Medicine that let me do this project, and the Harvard Macy Institute for my own professional development.
Hey, Beth, that was terrific. I learned a lot. Now the question is, will I retain it?
I hope so.
Could you make some suggestions? I mean, you must have thought about this a lot with the residents and the fellows in the clinic. How can we apply some of these learning principles to the teaching these guys and gals and having them retain that information?
Right. Yeah. So I think that's a great question, Chris. And we're struggling, like everybody is struggling with this. And I think really the important thing is that not all the learning is going to happen when we're in this computer, right? Some of the learning is going to have to happen before the learning, during whether the learning is a session like this where we're having a didactic, or the session is a telehealth visit with a patient. So I think the idea is to get prepared for the learning. So to either read or engage with material before, obviously engage during the session, and then afterwards to really sort of debrief on it. So that's one idea about sort of spacing out this learning. So it's not just this one thing that we're doing. And that was the idea actually about having our students do multiple choice questions. It prepares them for the learning. And I think we have to be really very, very much thinking about that. As we're planning our activities during this crazy time.
And one other question, there's a lot of upcoming changes from US and ACGME and et cetera. Do you have any comments on what we can expect in the near future for training?
So that's a loaded question, Chris. So with respect to, I guess maybe if you could.
Well, I'm reading all of these things about going to pass fail and these various things. I mean, you're in the midst of education, clinical education. I'm just wondering what you've heard.
Right. Yeah. So I mean, I think that there's been a lot of hankering about the NBME step exams, right? So the importance of the step 1 exam, it has outsized importance, I think, in terms of getting into residency, and people are knowledgeable about that, and may stunt foundational education if students are really just worried about taking that test. And so, many places have gone to pass-fail for exactly that reason, so that students can be a little bit more inclusive in their study. Now with the pandemic, I think some students are not going to be able to take some of the exams, and some of that's been put off. And so there's a lot of reorganizing of how that's going to be. Will students be able to take step 2 exam before they apply for residency? There's a lot going on there. There's not much, at least from the perspective of the NBME and fellowship training. You mentioned the ACGME, which is the other kind of alphabet soup. The ACGME, as I'm sure your fellows and your program faculty know, are constantly evolving requirements for our training programs, and they never go down, they only go up, more and more requirements. I mean, some of the new things are interprofessional learning, quality improvement learning, all these other things that are important in, how we do business in medicine in the year 2020. So those are all becoming part of the requirements.
Was there a question from Mark? Or let me see if I can open up this chat.
Yeah, I can see it. So Mark Wiener, hello. It says, for our chronic diseases, especially patient education and knowledge plays an important role in management. Do you have suggestions for patient education that use these principles? Thank you for asking me that question, Mark. I don't really work in the area of patient education, although I have to say I have done some studies on how much patients retain of what you tell them. And I've had people audio tape my interactions with patients, and you can hear what I told them, and then you can see what they retained, which is only a small portion of what I told them. So this is real. I think part of this is really understanding where our patients are in their actually medical literacy. You know, health literacy is really very, very important. And I think assessing your patient's health literacy is very critical. And we've developed a health literacy toolbox, and I'm happy to share that with you, but I think it's actually on our website, on the Thurston Arthritis Research Center website, which gives you sort of a toolbox of things you can do to help patients learn about their diseases, about their medicines, and how to communicate. So like the teach back method, really important. So if you're explaining to somebody, say, and I think there's a video of me doing this, if you're teaching someone how to up titrate their methotrexate and down titrate their prednisone, you go through that with them, and then you ask them to sort of repeat back to you what it is that you said. So there's lots of tools in that toolbox, and I'm happy to share that with you. And actually, I think there was recently a paper where someone actually used our toolbox and wrote a paper about it. So there's information out there on universal precautions for health literacy among patients.
What do you think, Beth, about patients now being able to see their notes from the clinic visit? Do you think that helps their literacy?
I don't think anyone looks at them. I think you can look and see whether anyone's actually looked, and my guess is nobody's looking at them. I think for some patients who are higher literacy, they may be reading them, and that might be helpful, but I don't know if anybody has done any work in that area.
Well, there was an interesting study out of Hopkins recently looking at a couple of institutions where the notes were available. And it was interesting that most patients said they understood the notes and that they were helpful, but they didn't go into deep, learning aspects of whether they learned anything from that.
Right. And I also think some of our patients are not literate in English. And that's a huge challenge. And those people are not going to be reading their notes. And sometimes they're not going to be understanding. And people who are not literate are often very good at hiding that. And so you have to have your antennas up and use all these other sort of non-literate tools to help people, pictures, numbers, other things that you may have to get very creative about, which is time consuming. Thanks, Elizabeth, for putting in the chat the link to our toolkit for patients. So yeah, it's in there. And Bernard said he thinks he can remember my dog chewing up the New England Journal for a very long time. You see that? So I showed you something that was memorable and funny, and now it's in your brain and you're not going to forget it. So sometimes you see things you really want to forget, but this is actually humorous, so you'll remember it, and you saw it here first.
All right.
She eats a lot of other things too.
Thank you, Beth. It's been great. Good to see you again.
Great to see you, Chris, and thanks for having me.
All right. Bye-bye.
Bye. Thanks, Laura.
Bye.